Welcome, everyone. Welcome, welcome. Hello. Gonna give it a couple more minutes while we wait for folks to join. Thank you for being here. We should be starting like around 3 or 4 more minutes.
Yeah, if you want to introduce yourself in the chat, go right ahead. We want to see where everybody's calling in from. It's so nice to see you here today. Thanks for being with us.
Awesome. Let's see who else do we have here. Got folks from Washington and Ohio and Kentucky. Welcome to folks from Kentucky, Ohio, Washington. California, Charlotte, North Carolina, Virginia. Awesome. Oh, there's Gabby. Do you wanna, what should I do? You got it? Thank you, Armin. Hola, Gaby.
Hola.
Ole, ole. Tiffany, you raised your hand. I don't know if you have a question or... Oh, tenemos una compa, una persona de Chile. Bienvenida. Qué bueno. Welcome from de Chile. That's awesome. La brigada callejera. Qué excelente. Oh, that's okay. No worries, Tiffany. So I think we should give it 1 more minute and then we should go ahead and get started. Awesome. We have Champaign, Illinois. Also in the house in New York. Welcome, everyone. From Alberta, Canada, right, Angela? Maybe, yeah. That's great. Adam, New York, welcome. Awesome. Yes, San Diego. Welcome, San Diego. Oh, Kate from Portland. Welcome, Kate. Oh, we have a colleague from South Africa. Welcome, Reginald. Bienvenida. That's awesome. And oh, Kimberly from Maui, from Hawaii. Great. Oh, that's fantastic. I love to see all these different places, folks joining us from all these different parts of the world. That's great. Welcome, Leah, San Francisco. Okay, so I think maybe we should just go ahead and get started. And as folks come in, we can welcome them into the space. So thank you for being here today. Buenas tardes, good afternoon, or good morning. I don't know, depends on where you're in the world, or good evening. Buenas noches también. My name is Tanagra Melgarejo Pulido, and I'm part of the National Harm Reduction Coalition. And I'm gonna let my colleagues introduce themselves. I'm gonna pass it to Gabby, who will be co-facilitating the session with me so they can introduce themselves.
Hi, everyone. My name is Gabby. I'm part of the NHRC team. I'm a licensed clinical social worker, and but mostly I've been working in communities for the past couple of years. And I'm really excited to be joining Tanagra and Harmony and Taylor in this webinar, and all of you.
Gracias, Gabby. So you want to popcorn it too? I mean, Harmony.
Hello, hello. My name is Harmony Seberg. I use she, her pronouns. I am, Gainesville, Florida. That's where I grew up. Amazing. I currently live in New York City, been here for 11 years, been at NHRC for 3. And yeah, I'll be doing a lot of stuff on the back end. Unfortunately, folks can't come off mute until we do our little section at the end, but there is a Q&A function. So if you have any questions, drop them in there. Taylor and I will be in the chat supporting with all the questions there. But yeah, happy to be here. And Taylor.
Thanks, Harmony. Hi, everyone. So nice to be here with you today. I'm actually calling in from Connecticut. I've been here at NHRC for a little over 3 years. Fun fact, Harmony and I have the same start date. So I oversee the Lighthouse Learning Collective here at National Harm Reduction Coalition. So if you're not familiar and you want to check it out, I can drop a link in the chat. But it's all about queer and trans people who use drugs and engage in sex work. So if you want to learn more about that, get at me, but I'm going to be helping with the chat. So keep it up. Yeah, welcome.
Thank you, Taylor, and welcome to everyone who's joining us. It's nice to see some names that we've seen here before and some other folks that are new and joining us. And so today's webinar session is going to focus, or we'll be focusing on the impacts of mental health and substance use stigma when we're working with clients or participants. And just to walk you a little bit through this work that we're able to do through this Opioid Response Network funding, and ORN works with community organizations in different states, providing folks with resources such as training and technical assistance to address how they respond to opioid and stimulant use, hopefully from a harm reduction lens, a person-centered lens. They offer great technical assistance beyond what we're offering here today. They offer requests, actually accept requests, I'm sorry, for education and training. So if you're interested after today's session in connecting with them to request technical assistance, feel free to do that. They're really eager to support folks in that process. You can request TA in general. If you're interested in requesting Harm Reduction Coalition or the National Harm Reduction Coalition to be the ones providing the TA, you can name that in the request as well. Here you have the email address to support, that you can use to submit those requests for technical assistance. We will also, at the end of this session, we'll be sharing this. We really appreciate your feedback and appreciate your thoughts and how, if this training has been a source of support, or if you enjoyed this session, or if you would like to see more sessions as this one, or if there's anything that Gabby and I can do differently next time we offer this session, we want to hear from you. So there's this link here, this QR code that will lead you to a brief survey that ORN is asking us to compile for them. It's important for us to be able to share this information with them because it's a way to also demonstrate the need and the importance of creating these spaces for community and for connection and for learning from each other. So again, we would really appreciate it if you could complete that survey and let them know what your thoughts are about this session and other sessions. And just to briefly introduce National Harm Reduction Coalition, and I love to see how other folks are introducing themselves into the chat. In the chat is fantastic. NHRC has been around for 30 years. We are a national organization that was started in the midst of the HIV/AIDS pandemic many years ago by a group of folks who identified as people who use drugs that were being left out of conversations that were happening at the state, at national, state, and local levels in terms of how to best address the response to that pandemic. People who use drugs were being impacted. People who use drugs were dying. We were not being included in those conversations. So we decided to do what we do best, which is to organize and to demand, to be involved in those conversations. And out of that, we were born, and we continue to work today in 2025 to create spaces for dialogue and action that can help heal harms that are caused by racialized drug policies. We do that through all of these different little buckets that you see on the screen. I'm part of the trainings and technical assistance team, but we do also offer all of those other services. So if you're curious about who we are, if you haven't heard of us, or you want to learn more, you can always hit us up, reach out to us. We'd be happy to chat more and get in conversation with you. And so in terms of what we're hoping to cover today, we want to start by grounding ourselves and I think it's important to level set to really make sure that we are all in the same place, en la misma página, you know, at the same page. Is that how you say it in English? I don't know, but I'll translate it from Spanish.
Probably.
We're in the same page. Sí, ¿verdad? Estamos en la
Sí.
misma página, we're in the same page in terms of like, how do we approach this from a harm reduction lens? When we're thinking of stigma. And so in order for us to do that, we want to do a review. So for some of you, this will be a refresher. And for some of you that may be newer to harm reduction, it'll be an introduction to harm reduction. So what is this approach and this movement? And we'll look at that and some very important concepts that are key for us to then enter into this conversation about what is stigma, right? And what is trauma. And then after we look at all of that, we'll be looking at how co-occurring disorders are present and impact our participants' lives and abilities to move through the world in a way that recognizes their full humanity. And then we'll look at tools. What are some of the things? Harm reduction is one, but what are those other things, other tools, other approaches, other philosophies, other practices that we can engage in that can help us challenge and counteract that stigma, right? And we're proposing person-centered care, person-centered engagement, and within that cultural safety, cultural and language justice and justice for people who use drugs as ways of framing from a harm reduction lens, this approach and this way of us connecting with people. So hopefully this is what you were that you had signed up for today, and I'm just really excited to be here. And I'm gonna pass the mic now over to Gabby, who's gonna lead us in the first part of the session.
Thank you, Donaira. So yeah, let's ground ourselves in what the harm reduction approach is. So harm reduction utilizes a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, and other behaviors that can be risky or potentially harmful. And that goes from safer techniques like, safer injection or safer smoking supplies to managed use. So that's when people feel like they can continue with their use without it being chaotic or problematic. How it depends on how you frame it. And then there's also abstinence. So harm reduction does not exclude abstinence from the approach. So I feel like it's important for us to mention that. Sometimes we have a skewed view of what harm reduction is, and we think that it's sometimes promoting drug use, but it's not about that. It's about giving people choices. And so on that note, not all drug use is the same. There is a continuum of drug use. So it goes from no use, right? Then it could be experimental or situational. It could be social. There's regular use as well, ritual binge, habitual or daily, and then there's chaotic and persistent. So I would like for all of you to think of some examples of each point in the continuum, because like I mentioned, not everybody is in that same point, and not everybody is in the same point with the different substances that they might use. So you might be a daily habitual kind of a pot smoker, if you will, but then you might indulge in a ritual binge with some other drugs. So it's good for us to have that framing and to think that, like the slide says, not all drug use is the same. So let's talk a little bit about the harm reduction movement. Harm reduction equates public health to social justice. And so public health aims to improve the health of entire populations. And social justice addresses the root causes of these health disparities that can affect individuals and communities. So social justice in this context means that everyone deserves equal rights and opportunities. And this includes the right to good health, right? So these inequities that in health that are avoidable, unnecessary, and unjust come from racism, stigma, criminalization that do cause a lot of harm. And so another one of the pillars of the movement is ending inequality and oppression, fostering health and liberation, while keeping leadership of the most impacted key so that we can build transformative change. which involves, fundamental system-wide reorganization across various aspects of society. And so, in this case, we're talking about people who use drugs. So that might look like access to safer supplies. That might look like more treatment options that are not based on abstinence, and so on and so forth. And so this type of transformative change that comes from the leadership of the most impacted aims to address complex issues. And so who better to talk about this and to transform the system than the people that live it on a day-to-day basis. So important, very central to the harm reduction movement and approaches is personal and bodily autonomy, which is an individual's capacity for self-determination or self-governance. And so working with people who use drugs requires respect for the choices of the people with whom you're working. It may not be the choice that you would make, and I feel like that's something, we have to work with our own biases, and but it is essential that we respect the choices of the person as their right. And so it recognizes that most often people are making the best choices they can with the tools and resources they have. So us as providers, we need to practice radical neutrality and acceptance. And so it requires a willingness to grapple with ethical gray areas, to tolerate, accept, and understand difficult behaviors. We need to learn from our clients and stop being the authority, the judge, or the expert, and become partners, people that accompany other people. And we do have our professional backgrounds, and we do have training, and we should put that to the service of the people that are making their own choices.
Thank you, Gabby. And now we're going to be looking at stigma, right? I think one of the things that when I hear, you share about personal autonomy and radical neutrality is this call to us as providers, right? To take a step back and to really allow participants to feel that they can come to us as they are. And many times one of the biggest barriers for that to be able to happen is stigma, right? It is societal stigma that pervades, como se dice, it's everywhere, right? It percolates everywhere and everything. It's like all of these invisible tentacles, right? Pervasive. Yeah, I don't know. I was thinking in Spanish or English. I made up a word. It's stigma's everywhere, right? And many times it is one of the biggest barriers that participants, clients, or patients have to be able to connect to us, to access services, to feel that they're deserving of services. So I would like to ask folks in the chat, if possible, if you can sort of share with us, when we think of stigma, when you think of what is stigma, what words come to mind? It can be a word or it can be a phrase. What comes to mind? What is stigma? Shame. I see a lot of shame in there, Junkie. Yes, that word, shame. Judgment, Tiara, absolutely. A tainted identity, prejudice, alcohol, lost cause, users, absolutely. It covers everything like volcanic ash. Oh my God, Angela, that's like a really interesting way of framing it. Like I could totally see it in my head. I'm visual. Misjudgment, othering, demonization. We're lost. There's comparison. There's discrimination, prejudice, assumptions. Absolutely. Microaggressions, Dante. There's bias, isolation, Farah. We're going to look at that. We're considered human garbage. Yes, Carly. Admonishment. Yes, Kayla. Absolutely. Absolutely. We're scapegoats, Leah. Yes, thank you. There's alienation, Justine. All of those are really good ways of defining what is stigma, right? So when we think of stigma, to me, when I think of stigma is something that if you have felt it, you know how it feels. If you've been stigmatized, and you know that it doesn't feel good. And sometimes it can be challenging to articulate that to someone, right? Because it's also, a stigma is not necessarily something tangible in and of itself. right? It is a concept, it's an experience, it's a way that we're perceived, a way that we, when we move through the world, right, we are able not to move freely, right? We're challenged, we're constrained, we're pushed aside, pushed away, invisibilized, right? And so when I think of stigma, sometimes it's easier for me to sort of internalize it and to understand what it is by looking at, by trying to make it be visual, right? And so when we think of stigma, and that's why I'm sharing this graphic with folks, hopefully it can help us to kind of dive deeper into what stigma can be for folks, right? Or it is for us. So when we think of stigma, it starts with ideas, right? And stereotypes that are here in our heads, right? People with substance use disorder are incapable. People who engage in sex work are dangerous. People with behavioral or mental health conditions are fragile. People who are unhoused cannot recover, right? So we start thinking about people in this way, and then we start creating stereotypes, right? That we start assigning to everyone that we think fits into that mold. And then from those stereotypes and ideas, right, we move into beliefs, right? Then it moves to our heart. Then we really start feeling that in our core, right? And we think, oh, these people who use drugs, they're scary, they're dangerous, they're shameful, they're less than, they're bad people, they're junkies, they're trash, they're not human, right? They're not to be trusted. And so those ideas then become beliefs. Then we start feeling that. And then when we feel something, then we start acting on it. And so we start seeing the discrimination. What we see is the actions. Usually, we don't see the beliefs and the ideas, but those actions don't come out of nowhere, right? There's a root, right, to those actions. And that root and that trunk, if we think about it as a tree, are the ideas and the beliefs. Right. And so here we have discrimination. We have the actions that are concrete that people who are stigmatized experience. And this discrimination can happen both at a social level and it can happen at a structural level. And I bet you that you probably have heard comments from people like, oh, I don't want that treatment center in my community, or I don't want that outreach van coming into my neighborhood. Oh, I don't want the harm reduction services van parking in the Walmart parking lot, right? I don't want those people's kids going to the school with my kids, or I don't want them living next door to me. I don't want them to be working with me, etc. So there's that social discrimination. And then there's the structural discrimination, right? When we don't hire people, right, to work for us, where we don't offer the same kind of support through health insurance coverage or education or capacity building for folks to be successful within systems and structures, right? I won't offer you access to this medication because I believe that as a person who uses drugs, you won't be able to adhere to the protocol that it's required for that person to take that medicine. So we don't, for many years, we didn't offer people who use drugs the cure for hepatitis C, right? Because we thought, exactly, Dante, exactly like that, because we thought, oh, they're not going to be able to do that. That's discrimination. And that discrimination is rooted in stigma. It's rooted in stereotypes and prejudice and beliefs that we have about people who use drugs. And I'll give you an example of National Harm Reduction Coalition. When the initial executive director from NHRC, he transitioned out after 25 years of leading the organization, we had a new executive director come in. Her name was Monique Tula. And Monique came in, and one of the things that NED would do as they come in, they start reviewing policies and practices and everything. And Monique, as she was reviewing our health insurance, realized that our health insurance did not cover medications for opioid use disorder, right? So we had colleagues in our staff that work with us that were taking those medications, that were paying out of pocket from their own pocket to access those medications because the health insurance didn't cover them. So that's interesting in and of itself. But more interesting to us is to ask ourselves, you know, what happened there that our colleagues didn't feel that they could come up and share and say, hey, our health insurance sucks. It's no bueno. It's not covering my medication. Would someone that needed an asthma inhaler or maybe needed some insulin, would people feel like I cannot name that this medication is not covered, you know, a heart medication, right? So again, the root there is internalized stigma, right? And so how it prevented our colleagues from naming those things. And so what Monique did was, you know what? We're going to make sure that we have health insurance that covers all of these things so no one feels they have to ask because it's covered for everyone. We're going to make it universal. What is good for one group is good for everyone, right? And so thinking about, how do we analyze, right? How do we not take things for granted, and we analyze our policies and our practices to ensure, right, again, that they're not discriminatory, that they're not stigmatizing to our people, that even us as harm reductionists many times can fall into the trap of stigmatizing folks, either our own internalized stigma or stigma that is projected onto us. And so as we were talking, stigma is a social process. It happens between people. It's a societal issue, right? That reinforces relationships of power and control. I get to say that you're a bad person. I get to push you aside. I get to make myself feel better. I get to stand here and feel that I'm invisible, right? That I am morally superior to you because I am saying that you're a bad person. And that means that I can control you, that I have power and control over you, that I get to tell you what you need to do and how you're going to do it. And that means also that for those of us that are stigmatized, we are considered garbage, right? It leads to status loss. We're less than. We're not even human. And we're getting discriminated because of our substance use, because of our sex work, because of those behaviors that are considered shameful, right, and less than. And so stigma is the belief. It's here, right? And discriminations are the actions, are the things that we do, are the things that we see, are the experiences that people have to bear, right, many times in order to get to access certain services or to be denied of services. And there are several forms of stigma, right? There's, as we were talking earlier in the chat, there is stigma from individuals, right? And we may see this. I used to work at a drop-in center, and it was a drop-in center for people who use drugs in the community. And I always love to listen to conversations that happen. And some folks would say, oh, at least I am not shooting up or nodding off because I'm using an opioid. And someone else said, oh, at least I don't smoke crack, right? And so you're thinking, well, we're stigmatizing each other, but ultimately we're receiving stigma from society because everybody who's here is considered less than because they're using drugs, right? Then there's the examples of institutional stigma. I shared one about NHRC, but I've seen other examples that people have shared with me of participants going into buildings to go to appointments and having the security officer in the building walk them to and from the office when they're not doing that for anyone else, right? Or asking them to go through secondary checks because of how they are perceived, right? Or being denied access to services because they don't seem that they're safe to be in that space. That's institutional stigma. Then there's the stigma. Yes, Gabby,
I
go for it.
add, sorry.
No, sin pena.
It's happened also with dress codes. People that I've accompanied to appointments, maybe they don't have the clothes to go into the building, and that is also a form of stigma. If you're working with a street-based sex worker who is showing a lot of skin, in Puerto Rico, she will get denied care because of the way that she is dressed. So that's just another example that came to mind.
Yeah, thank you. And that's happened to me. I've experienced that many times. I've worn shirts and I've been turned around. I'm like, why? My arms are going to like, what is happening?
Am I offending you?
Absolutely. Something's happening with that. But then we have the self-stigma, and that's the stigma that is internalized. And that is really pernicious and harmful and dangerous because that's the story that we keep telling ourselves. I'm a bad person. I'm less than. I don't deserve care. I don't deserve love. I don't deserve acceptance. I cannot embody my power because I don't deserve to use it. I'm dumb. I'm not smart. I'm bad. All of those things that we tell ourselves. And then the stigma through association, right? When we are connected or in proximity to a community that has been stigmatized. And then because of that, the stigma also impacts us. I had a participant when I used to work here in Puerto Rico at a domestic violence program that was a participant in our program. And she was sharing a story that, she lived in a small town here in Puerto Rico and her mom was the sex worker in the community, right? And her mom had engaged in sex work for many, many years and had been stigmatized for that. And because she was her daughter, the assumption was that her daughter also not only was a sex worker, but got treated just as poorly and in such a discriminatory way as her mom had been treated, right? So she was navigating that as well. It's like, I love my mom. I don't want to shame my mom. And also I am angry at my mom because I am getting treated and dehumanized in the same way that she has been treated and dehumanized because I'm her daughter and I'm connected to her because of that association. So that stigma through association, right? That we see where we dump everyone in the same bucket and treat them the same way because of assumptions that we make about them and who they are. And then there are some key elements to stigma. We have the functions, right? And then we have these key elements of stigma. Stigma is here because it's set on blaming people, because it's set on holding certain moral judgments about who human beings can be or should be, right? And so we feel that people who use drugs are in the situation that they are because se lo buscaron, because they provoked that. The same thing I've heard about survivors of intimate partner violence. So she must like it. She must have done something to get him that angry, to hurt her or hit her, right? And there's this moral judgment. How can she stay in that relationship? You know, I would have left in a minute. Oh my God, I cannot believe that she didn't see that coming. Like, how come, you know, she didn't leave earlier or sooner, or she keeps coming back, right? And so there's that blame and moral judgment that also speaks to superiority, that somehow I feel like I could have done it differently when I've never been in those shoes, right? There's the criminalization, the surveillance of folks that are different or that don't fit within the norm that we're comfortable with, right? And we also pathologize and patronize people. This happens a lot with people who use drugs, and it's connected to that concept of autonomy that Gabby was speaking earlier to, you know, where we don't allow people to make decisions. We don't give them room to make decisions. We just tell them what they need to do because we feel like they can make that a good decision. They don't know how to do it. Yes.
Exactly. I was just gonna say, so we infantilize them as well. Sometimes, as providers, we can fall in that trap of feeling like we know better, and that people are just not capable of making choices, the right choices, with the information that we give them. So we just make the decisions for them, and that is very patronizing, and it is detrimental to the autonomy of the person because you disempower them as well.
Absolutely. And also we assume that they don't know. It's like we assume that people who use drugs are empty vessels, like Paulo Freire used to say. The thing about banking education vis-a-vis education that is liberatory, that is popular education, that is education that is rooted in centering people's autonomy, is that when you do banking education, you feel that people are empty vessels or you're gonna drop the knowledge in. Right? It doesn't take into account people's lived experience, where they have been, their identities, how they move through the world. And so when we move from that framework and we pathologize and we patronize people, we also assume they don't know. Instead of asking ourselves, maybe they know this information, can you tell me more so that I can find out? We say, I'm going to give all this information to you because there's no way in heck that you can have it or know it, right? And that's a missed opportunity for connection and for us to learn from each other. And then finally, and the most horrible thing about stigma, one of the key elements that is, they're all really harmful, but this one is particularly harmful, is fear and isolation, because ultimately stigma kills because of this, because people are unseen, they're unheard, they're so dehumanized that to the point where people no longer feel like connecting, and that's when death happens, right? That's when death appears, and that's terrible. And I am gonna pass it over to Gabby, right?
Okay.
Yeah.
So keeping it up with, kind of the key elements, let's move on to like the functions of stigma. So it's a complex social phenomenon with multiple functions, which serves to maintain social order. For the people that stigmatize other people, they feel better about themselves, so they enhance their self-esteem and to justify exploitation and oppression. So it does allow those in power to maintain control and resources. So the function is to keep the difference, to keep people out, to keep people away because we think that they're dangerous, and we become discriminatory with our actions, keeping people down. And so by associating a stigmatized group with negative attributes, it becomes easier to justify their exclusion from opportunities, from resources, and it can serve as a mechanism for enforcing, like I mentioned, the social norms and expectations. And so individuals that deviate may be for drug use or sex work or any other risky behavior, they face the stigma, and it's supposed, the a function is supposed to, discourage them from continuing with this behavior. But as we know, it just causes harm. And yeah, so let's move on to the cycle of drug related stigma. So stereotypes and labels, that's how it starts. Like I mentioned, like Danagra mentioned earlier, we say very horrible words that we're going to talk about language later in a couple of slides. But we call sex workers hoes, or people that use crack, crackheads, and it starts with the labels, and then the expectations is that, for example, people who inject drugs are going to share the equipment because they're irresponsible. And that goes with the labels. So we label them irresponsible, so we expect them to be irresponsible, and then we limit their opportunities. Like Danagra had mentioned, it's harder to get treatment for hepatitis if you inject drugs or if you drink alcohol, because they think, misinformation and the stigma that is being reinforced. And then it is internalized and reinforced. So once the person finds out about a diagnosis and they know that, they use drugs or they engage in sex work, then they start feeling guilty about it. And then they start feeling shame. And then that's the end result, is the lived experience of stigma. And then we also reinforce that with the labels, and it keeps going on and on. And so to kind of counteract that, we have the virtuous cycle, which is a positive self-reinforcing loop where trust leads to more positive outcomes, which in turn further strengthens trust. And so this cycle can be seen in relationships, businesses, and in a larger societal, scale. And so it's important to know that development of the interpersonal linkages is what I mentioned about it being in relationship on a one-on-one kind of level. And that leads to creating an organizational climate of trust. And then that makes the participants kind of rebuild that trust on the system and the providers as well. And which leads to cultural safety, which Tanagra is going to go a little bit deeper into in a little bit. Some questions that we can ask ourselves is, what is culturally safe care for people who use or used drugs? And an important factor to keep in mind is that whether a place is safe or not is defined by those who receive the service. Like I mentioned in the harm reduction movement, we need to center the people with the lived experience, like either past or present. We need to keep that centered. And so let's talk a little bit about language. Language plays a crucial role in establishing rapport with participants. And so by using person-first language in our intake forms and conversations, we separate the individual from their behavior/health status and create a more welcoming environment. And so the words we use can help or hinder our relationship with participants. And oftentimes we unknowingly use stigmatizing words or terms in our intake forms and interactions without even realizing it, either because we don't have the lived experience, or because we just follow the norms, or because we come from a clinical setting which uses very different language. But so on the left, we have the stigmatizing words that can be derogatory, right? And so instead of saying drug addict, let's say person who uses drugs. Like I said, person first language. Instead of prostitute, person who does sex work, or sex worker. Instead of drug problem, well, it's substance use. And if there's a diagnosis, then you add the disorder part. Instead of using the binary clean, sober, let's use abstinence because that is more true to facts, and it's less of a moral judgment. Crazy, we are talking about the impacts of also mental health, and so calling somebody crazy, unless they want to be called crazy, which is a different story, then we are keep reinforcing that stigma. So we just say person living with mental health issues. And lastly, infected with HIV or Hep C, it's a person that lives with X, Y, or Z disease. So the good thing about person first language is you can apply it to everything. Just center the person and not the behavior, or the health status or whatever else might be happening on with that person. And so an important note, which is down below, people with lived experience or living experience may self-identify with language that may not be appropriate to use as a service provider. So you should refrain from armchair diagnosing, and unless a person asks you to call them in X, Y, or Z way, then you should just avoid it to avoid the stigma and discrimination.
I was going to say also, Gabby,
Yeah.
with that one of the things that I have sort of understood from my practice is that we have room to help people be bilingual, right?
Mm-hmm.
And bicultural, in the sense of like when we're working with people who use drugs, it is a safe space for you here because we have built it together for you to use this language, right? And when you say drug addict or you say junkie or you say drug fiend, I understand that. And I see you beyond that. I see who you are. And I understand that you're using that language and that you're taking it and using it for because you feel that that's the language you want to use. And I'm not going to tell you not to. And also, how do we support folks to be able to take other terms, this person first language, so that they can use it in context where the person in front of them is not able to do that translation in their head, right? So sometimes I'm like, how would it be if you went in front of a judge, right, and said to them, oh, I'm a drug fiend or I'm a crackhead, right? How do you think that they will see you, right? So it's also helping folks to be able to take this language, right, so that they can be safer in other spaces where this translation or interpretation of what this person means, the person that is there cannot do that or is not able or willing to do that, right? So it doesn't create more harm for them too.
And also by providing person first language, we are helping people fight the internalized stigma that comes from using a language that is not centering yourself, that is centering the behavior. And so I wanted to talk about stigma in service providers. This was a study done in 2023, stigmatization of people with addiction by health professionals. It's a review. And so from 19 reviews, only 20 to 51% of health professionals had negative attitudes / beliefs about substance use disorder. However, I feel like that number is really high, even though it says only. And so addiction training and clinical experience with people with substance use disorder were associated with a less negative attitude. And health professionals' negative beliefs, lack of time or support were associated with less involvement in addiction care. So the people are not getting the services because they are feeling stigma from their providers, basically. And so tobacco use disorder, substance use disorders other than alcohol and tobacco, relapse, psychiatric comorbidity, or criminal records were associated with a more negative attitude. So basically, the stigma that the providers are putting on the people that are receiving the services have to do with their internalized ideas of what a good patient, client, etc. looks like, which is somebody that does not have a criminal record, that is abstinence, that etc. etc. etc.
Thank you, Robbie. And so I think also, and this is connected to what you were saying, us as providers, right? this is calling upon us to also engage in a process of self-reflection, right? Of who we are, what do we bring to this work, how do we come to this work, understand, right, that stigma doesn't happen out of nowhere, right? That there are a lot of complexities around people's identities more now than ever in a world, in a society, or in a reality that we're living in, that it's intent on erasing many of us from existence, right? We cannot even name certain things. And so thinking about, the impact of those complexities, right? And how those identities intersect in ways that may create more vulnerability for people because the system refuses to allow them to be who they are, because it sees them as dangerous, as bad, right? As other than. And also to acknowledge that we are working with people and we're working within those same systems, and we are also involved in those systems, and that those structures also impact us. They also harm us. They also burn us out. They also violate our human rights. So we're not immune to this, right? We are holding space for people to process with us the harms of the trauma. We're going to get into the second that stigma can cause for someone. And also some of us may also experience stigma ourselves, right? So there's this dual layer, right, that we're addressing and dealing with. And so I would love to ask folks if you can type in the chat, what comes to mind when you think about trauma? What is trauma? You can, what words come to mind? Harm, thank you, Dante. Fears, flashbacks, a reaction to harm, past pain. Thank you, Marquita. Nightmares, thank you, Kayla. Absolutely. Fear. Nervous system dysregulation, we're replaying something that we also is creating fear for us, is lasting. It can be rooted in early childhood outcomes, impacts our neurology. Elevated heart rate, absolutely. It's an adverse effect on us physically or mentally. Mental disturbances, absolutely a bad experience. Witnessing violence or witnessing abuse, etc. Thank you, everyone. When we think of stigma, and we think of, I think we need to think of trauma too, right? And many times stigma generates a lot of trauma for folks, how we are treated by people. When we're stigmatized by systems or folks, it really can create trauma for us. And so when we think of trauma, I want us to think about the 3 E's of trauma, which are the events, the experience of the events, and the effect of those events. And this is a definition that we're borrowing from SAMHSA. And I would love to hear from folks what you think about it. So SAMHSA is telling us that individual trauma results from an event, a series of events, or a set of circumstances that is experienced by a person, an individual, as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on that person's ability to function, their mental, physical, social, emotional, or spiritual well-being, right? So when I think of this definition, right, I think about, how trauma can have many different manifestations for someone, and how not each person will respond differently to trauma and to a traumatic event, right? Oh, yes, we're going to look at that in a second, Carly. We're going to get to that. We're going to look at the other, this is an individual on one person, but we're going to look at the fact that trauma also can expand to communities, right? And into networks as a whole. So thank you for lifting that up. We're going to look at that in a second, right? And so important for us to think that, and remind ourselves that just as harm reduction is telling us that our approach should not be a one-size-fits-all, because we're working with individuals that are different. We may have a shared commonality, which is that we use drugs, and also the impact of that substance use, our reality, who we are, our identities make that reality different for each of us. Like I may wear 7.5 size shoes, and Gabby also may wear 7.5 shoes. And when I put Gabby's shoes on, they feel different because Gabby steps differently, right? And her foot falls in a different way. And if Gabby put some mind may find them really uncomfortable. Like, damn girl, like these shoes are not as comfortable, right? It is different, right? That we wear the same shoe size doesn't mean that they're gonna feel the same, because they're not the same, because we're not the same. So I was always thinking about, when we think of approaching folks from a harm reduction lens and from a trauma-informed lens, is really uplifting and centering that person's humanity and that person's autonomy and who they are and who is sitting in front of us, right? Also, when we think of trauma, as you were saying, Carly, there's collective trauma, right? There's interpersonal trauma and there's individual trauma. There's my trauma experience as a person. There's interpersonal trauma that happens across people in communities, family members, friends, etc. And then there's the collective trauma that we may hold as broad groups of people because of violence such as slavery, because of violence such as xenophobia, etc., right? So some examples of that collective institutional structural trauma, and I'm just gonna keep talking, but I need to open the door for my puppy because she decided she needs to go out, and it's gonna keep looking at me like she's about to bite me. There's some examples of trauma. I look at that institutional, structural, right, intergenerational trauma. And there's more. We have some here. So if you can think of others, you can add them as Carly did in the chat. We have the mass sterilization of Puerto Rican women in the 1950s and 60s by on a project that was authorized and supported by the US government called La Operación. This mass sterilization of Puerto Rican women was also done without their consent and their knowledge. They were told that this operation was reversible, and actually was not reversible. And also women were not consulted. People with uteruses were not consulted. The husbands of the people with uteruses were the ones that actually had signed the consent. So the person didn't even know what happened to them. The colonization of the Americas, right, as a historical example of trauma, right? Natural disasters. We have hurricanes, floods. In California, I remember when I lived in California, the fires that happen every year in many areas of California. We just had a huge experience of a terrible trauma that folks experience in Los Angeles, in the Los Angeles area, because of the fires, earthquakes. Dante, absolutely, the trauma of institutional neglect during the beginning of the AIDS pandemic on folks that are LGBTQI folks, absolutely, 100%. We have intergenerational trauma, enslavement, and there's a film, A Slavery by Another Name, that speaks to that. We have the foster care system, absolutely, mass incarceration, the war on drugs, right? It's trauma. We can have individual examples of trauma when we have physical attacks or intimate partner violence, right? And also that can also percolate to people in the network, right? If my partner is abusing me and I have dependents, my siblings live with me, they may also experience some of that trauma as well, vicarious trauma. Homelessness, right? And more now than ever, when we see that we have legally, this country, the United States, has allowed people who are unhoused to be criminalized through the Grant Pass Supreme Court justice decision, right? Again, the criminalization of people, right, by the behavior, but it's the bodies of people who are being criminalized in communities. And then, any trauma that is vicarious is trauma that changes us through exposure to traumatic stories and experiences of others, right, through the work that we do. The political trauma from our bodies being legislated, again, absolutely, Sarah. Yeah, when you feel that the system is completely hostile against you and your existence and doesn't want you here, there's collective trauma and individual trauma, right, around that as well. And so thinking about, us as people who do this work, we're committed to these communities and committed to fighting this fight, right? And that, in order for us to do this work, we create these containers for people to come as they are and be who they are and share with us their stories. And that is a privilege, and it is an honor. And also, the system doesn't care for us, as we were talking about earlier. And when it doesn't care for us, it leads us to vicarious trauma, because we don't have the outlets as providers that we deserve and should have to be able to process, these experiences, and to process them and to hold them in a way that doesn't harm us and harm others. And so that's also why we need to be also questioning and challenging the systems and structures, because they're here to, as a capitalist system, to exploit us, to burn us out, and to throw us aside and throw us away, right? And so I'm going to pass it now to Gabby, who's going to lead us through this section.
Thank you, Tanaira. So, a way to counteract and to address trauma is trauma-informed care, which is an approach in human service field that assumes that people are more likely than not to have a history of trauma. And so it recognizes the presence of trauma symptoms and acknowledges the role it may play in a life, including, like Tanaira's been saying, the program staff. So the intention of trauma-informed care is not to treat symptoms or issues related to any other forms of trauma, but to provide support services in a way that is accessible and appropriate to those who have experienced trauma. So that basically is the approach. And now I'm going to talk to you about the 6 core principles. And so the first one is safety. So throughout the organization, staff, and the people that we serve, whether it's children, adults, like they should feel physically and psychologically safe. So the physical setting and the interpersonal interactions promote a sense of safety. And so we also have trustworthiness and transparency. So the organization operates and the decisions are conducted in a way that is transparent with the goal of building and maintaining trust with clients, with family members, among the staff, and basically everybody that is involved in the organization. So the next principle is peer support and mutual self-help, which are key vehicles for establishing safety and hope, to build trust, to enhance collaboration, and for peers to use their stories and lived experience so that they can promote recovery and healing. And so peers are, right, I should have started with what a peer is. It's individuals with lived experiences of trauma, or children, or not necessarily, we're talking about trauma-informed care, but peers in a more general term, it could be used for people who have lived experience with drug use, with sex work, or with other behaviors, and they are there to provide support. Some peers in the trauma informed kind of setting have call themselves trauma survivors, but that is something that each and every person can choose for themselves. So another of the core principles of trauma-informed care is collaboration and mutuality. And so importance is placed on partnering and leveling power differences between staff and clients and the organizational staff. So I think that it's really important that we address that there is always a power dynamic when we are providing services, because either because we believe we're the authority, or because the client or participant believes we are the authority. We have the infrastructure. We are in a, it might be an outreach setting, it might be in a clinical setting, but you are seen as the expert. So collaboration and mutuality kind of wants to level that power imbalance that there is. And so it demonstrates that healing happens in relationships and in the meaningful sharing of power and decision making. And so for organizations, it's important that they recognize that everyone has a role to play in a trauma-informed approach. And I read this quote. This is from SAMHSA's, the same we were talking about earlier. It says one does not have to be a therapist to be therapeutic, and that really stuck with me, because you can be, as a person, a safe space for other people as well. You don't have to be in a clinical setting. You don't have to be licensed, anything, to be therapeutic. And so another of the 5th core principle is empowerment, voice, and choice. And so I'm going to stop here a little bit, kind of dissect that a little bit. So throughout the organization and among the clients served, individual strengths and experiences are recognized and built upon. So it's important and that we don't problem solve, and I'm going to talk about that in another slide, but we're not there to solve people's problems. We're there to help people brainstorm and feel that they have the power over their own lives and that they can make the best choices for themselves. And so in an organizational setting, the organization fosters a belief in the primacy of the people served. I don't know if I said that word right. In resilience, in the ability of individuals and communities to heal and promote recovery from trauma. And so operations, workforce development, and services are organized to foster the empowerment for staff and clients. So I feel like we're talking about vicarious trauma and all of that. Like we need to take care of ourselves and we need to promote that in our organizations as well. And so we also need to understand the importance of the power differentials, like I mentioned, because clients historically have been diminished in voice and choice, and they are often recipients of coercive treatment. And so we need to fight against that if we are going to come from a trauma-informed place, and provide that care. And so clients should be supported in shared decision making, in choices and goal setting to determine the plan of action they need to heal, to move forward, to kind of not stay where they're at. Because if they're coming to you, it's because they don't want to stay where they're at. And so the last principle is cultural, historical, and gender issues. So we need to move past cultural stereotypes and biases. It might be on race, ethnicity, sexual orientation, age, religion, gender, you name it. We need to offer access to gender responsive services. We need to leverage the healing value of traditional cultural connections and incorporate policies, protocols, and processes that are responsive to racial, ethnic, and cultural needs of the individuals that are receiving the services. And so, like we've mentioned, there's historical trauma, and we also need to address that when we're provided trauma-informed care. And so on to the next slide, let's talk about the trauma-informed perspective. So I say we're not here to problem solve, because when we look at it from the problem-focused perspective, we can think of a person as being oversensitive and reactive versus thinking about it from a trauma-informed perspective where people can be re-triggered. And so people feel strong emotions and react accordingly, and we should be able to hold that and be supportive of it. And sometimes people yell and they're not yelling at you. They are just reliving an experience that you might have triggered. And so that goes hand in hand with thinking of people as being aggressive. And so people, if we think of it as people being hyper aware of their surroundings, well, that's a better framework for us to be working from, because we also can regulate ourselves. And so we can think of, oh, this person is not aggressive, they're just hyper vigilant. What can I do to help them not be as hyper vigilant by creating a safer space? And so from a trauma-informed perspective, shame can be triggered when help is offered. And so I've seen people write in notes like, oh, not adherent to treatment, refuses treatment, et cetera. But what is going on? What can we do for people to want to accept what we have to offer? And so when we say there's no motivation from the problem-focused perspective, we could counteract that with thinking that the person has depression or PTSD, and avoidance is a way to manage that discomfort. Avoids people. Well, a way to manage stress and retriggering is avoiding people, like I mentioned earlier. And so we need to come from a compassionate place. And lastly, disengaged from a problem-focused perspective could be transformed into, could be experiencing dissociation from trauma, which is a mechanism that we use to protect ourselves. And so let's move on to the 4 R's of trauma-informed care. And so we realize that's the first R, the widespread impact of trauma, and we need to understand potential paths for recovery. And so then we move on to recognize those signs and symptoms of trauma in clients and family members and staff and others that are involved within the system. The next step is to respond by integrating what we know and making it policy, procedure, practice, protocol. And then we resist re-traumatization, of children as adults that care for them, as people with lived experience. And so I want you to think about creating that kind of safety in the physical environment. So, in what ways do staff members recognize and address aspects of the physical environment that may be re-traumatizing? And how do we work with people on developing strategies to deal with this? How have our agencies provided space that both staff and people receiving services can use to practice self-care, for example? And so there's a lot of many other questions that we could be asking, ourselves in terms of how can we integrate trauma-informed care and into our practices. Did you want to say something else, Anagra?
No, I think that when we're thinking of what we looking at in a little while about like 2 other strategies that we can integrate, right? I think as you said, we don't have to be therapists to be therapeutic. We don't have to be therapists to be a safe space for people. We don't have to be therapists to understand or try to understand the impacts that stigma and this kind of violence can have on participants, right? And I think part of it is asking us to be willing to do that and to be really thinking about how can we set ourselves to succeed by understanding, by being able to understand some of these things, by looking at it through this framework that you're sharing, right? And I think another piece that we can look at in terms of, some of the structural violence that people experience and the trauma that people experience when it comes to co-occurring disorders, right? When we comes to this, which is nothing more than like what we've been talking about, the intersection of folks that may use substances and also may be experiencing mental health conditions, right? Many times there's a lot of judgment around folks that may be using substances and also experiencing mental health conditions. And for me, what I've heard from participants is, I went to I've never been diagnosed, never had the opportunity to be diagnosed. I've been using substances to help me navigate the voices or the anxiety or the fear that I have. And substances have used me to do that. Some folks have been diagnosed or misdiagnosed, and the medications that they have been prescribed, is that how you say it? The prescriptions that they have received to manage those have not been effective. And so substances are also like using substances can help with those, right, to manage those symptoms. So the reality is that many of us are working with participants that are living or moving through the world and within this Venn diagram, within that sphere of the co-occurring disorders. And this system is intent on siloing them. It's telling people, I will only deal with your mental health condition if you stop using drugs. Or I will, if you, or if like, or I want to deal with your use of drugs has caused your mental health conditions, right? And so I need to look at one or the other, and we cannot look at the whole person-centered care. I was going to look in a moment. And as I was saying, go ahead, Gabby, you wanted to say something?
Yeah, I wanted to say that they're from a clinical perspective, mental health and substance use disorders share some underlying causes, which is why it's kind of difficult to parse it out, which include changes, in the brain composition, genetic predispositions or vulnerabilities, and also that historical and intergenerational trauma that we carry within our bodies can show up in these different ways.
Thank you. And many folks are going through the world that are living with substance use and mental health conditions, right? And they may also occur more frequently in folks that are experiencing depression, anxiety, schizophrenia, or personality disorders. So anyway, this is all to say that we need to sort of be operating from this mindset too of how do we support folks that may be experiencing co-occurring disorders, because co-occurring disorders touch every aspect of people's lives, right? From legal matters to our trauma history to our family dynamics. to our medical conditions, to our ability to connect or maintain or sustain relationships with folks, our ability to find educational opportunities, how they impact potential legal matters, right? As both substance use and mental health conditions are present, we know that many times the folks that are called to respond when people are navigating some destabilization or some issues related to this are the police, who are not equipped because they don't have the background, the expertise, and the knowledge and the training to navigate this. And what happens is most of the times we see headlines, oh, person who was living with X mental health condition is shot to death by a police officer that came to intervene because they saw them as a threat. They didn't see a human being that was in that moment experiencing a crisis. A mental health or an emotional crisis, right? So it's thinking about how all these things touch our lives, right? And also, I think this is me, yeah. To think about as well. I can make sure I'm not taking over the yeah. Thinking about again, how do we break the silos and how we work with the whole person? When we think of people who use drugs and people who are engaging in substance use, is thinking about the fact that many times what we taught to do is to really think about the drug itself, and that's the only space that we spend a lot of time in, like asking questions about that, like really inquiring about the drug itself. And that piece is important, don't get me wrong, because understanding what is behind someone's substance use in terms of the particular substance can give us an insight into that person's experience, that person's needs, etc., right? If a person uses opioids versus stimulants, if they're injecting versus smoking, all of that is important. But then we also have to look at the set and the setting. Who is this person? What is their mindset? What is the setting that they're in, their physical and social environment? All of those things have to do and influence a person's relationship to a substance and their person's trajectory with their substance use. Many times we have been able to show that if you're able to impact that set or the setting, the mindset, the person or the space, the physical and social space, that will have an effect in that person being able to transform their relationship to a specific substance or to their relationship to their substance use. And we can see this through wow, that was really hard for me to say, through two, that was hard for me to roll off my tongue, my apologies, through two different studies that have been carried out that have been seminal and really important in helping us understand this and sort of go deeper into it. The first one is drug set setting, which is a study that was carried out by Dr. Noam Sternberg between 1972, the year I was born, and 1984. And he found through his study 3 major criteria for what he considered benign or chaotic use. The drug itself, which is a type of drug, the set, which is the mindset that the person brought to the space, and the setting, the context, right? And here is an example. Let's say Thursday or Friday night, when we used to go to the office, at 5 o'clock or 4 o'clock, as soon as we were let out, it was like people were like happy hour, right? And you would go to happy hour and you would have a couple of glasses of wine and you would hang out with your friends and it would be really exciting. Maybe we'd do a little bump of Coke, maybe smoke a little bit, right? And let's say that Friday night, that Friday, I'm leaving work and I just found out that I've been promoted, right? So I'm going to go out and I'm going to go with my friends and I'm going to go to the bar. I'm going to have a couple of glasses of wine and I'm going to do a couple of bumps. I'm going to have a great time. And that's fantastic. My mindset and my set are I'm with people that I'm safe with, my friends, and I am excited. I am celebrating and I'm using those drugs because it's a way to enhance that celebration, right? So the way that my drug use feels would be different than if I was on a Friday afternoon, called to my supervisor's office and I was given a box and a letter telling me that my position has been done away with and that I am being fired. I'm being laid off, right? I no longer have a job. And so I may go to the bar, I may have a couple of glasses of wine, but the purpose of those glasses of wine is not to celebrate, right? Because my mindset, right, feels different. And my setting is I'm not with my friends, I'm with strangers. So that may not feel safe for me, right? Just thinking about the different ways that if we influence these two things, we can influence also someone's use and also the ways in which they engage with their use to make sure that it's safer for them. And then we have the Vietnam studies, which were carried in 1974 by Lee Robbins. And what he found out through these studies of Vietnam veterans that had used drugs in Vietnam and had come back to the United States or where they lived, is that 99% of these folks were able to stop using substances on their own, right? And when they were asked, how were you able to do that? Yes, the rat part, Angela, also another great example. They said change in stress levels, change in environment and family perceptions of drug use, and also the set and the setting, hopes, goals, ideals. I'm a different person, I'm in a different context, I want to do different things. I don't have to think about saving my life or witnessing, you know, like genocidal murder, right? And fearing, you know, what that means for me. I am in a different place, right? I have different expectations, different hopes, different desires. And so these two things show us, these two studies, that asking about the substance is important, but we cannot stay there, particularly when we're working with folks that are experiencing trauma and co-occurring disorders and experiencing stigma. That is really about rooting ourselves in who is this human being beyond their use.
And so that takes us to person-centered care, which is an integrated healthcare services delivered in a setting and manner that is responsive to individuals and their goals, their values, their preferences. It's important that it's done in a system that supports good communication between providers and patients and empowers individuals receiving care and providers to make effective care plans together. So it's like, you know, a recurring theme for us is, you know, that respect of body autonomy and seeing the person as a whole, which drug set setting provides this for us. Trauma-informed care also kind of frames it in that way. And so how does person-centered care and harm reduction relate to each other? So people who use services work in partnership with their health and social care professionals. They're treated with dignity, empathy, and respect. And so they're supported to develop knowledge, skills, and confidence to make informed decisions. And so, you know, that I feel like that we as people that have had access to a lot of information and a lot of training owe it to our participants to share that information and not to gatekeep what we know so that they can make informed decisions, how to manage their own health and their care and tailor everything to their own individual needs. Because the person is the expert in their own lives and they know what they need better than we can tell them, you know, what they need.
I think that we can also work together with participants, but this also has to start with ourselves. We have to be willing to do this practice, right? Of like creating a space of cultural safety. What does that mean, right? When we think of cultural safety, it means very basically we show respect and we show understanding. We do that through dialogue, to engaging in being willing to engage in processes of conflict recovery and problem solving with people. And that means that we have patience with ourselves, we have patience with participants, right? It takes time for people to feel that they can trust us, right? And to truly build that relationship of rapport and care. It is about listening carefully. That is super important to build trust and rapport. We want to be observant, right? More observing than talking. We want to assume that people's experiences are complex. We're multidimensional human beings, not one dimension, right? So that complexity is really important. There's richness in people's lives, and again, there's a lot of depth to people's experiences that we want to be able to create a space for folks to unpack with us in a safe way or in a safer way. It means that we are open to being flexible, right? I think that one of the things that harm reduction has taught me, and that I have had to sort of confront myself many times, is being willing to be flexible, right? And being flexible is like sort of like giving away this notion that I have to control everything. White supremacy culture tells us that we have to control every single thing. I think being flexible is, how can I make this work for the person who's here for the services? Not necessarily for me, although I am part of this equation, but we have to find a way of making this work for both of us together and thinking outside of the box. We have to be resourceful and creative. We also have to pay attention to how we're feeling. When I think, Gabby, you mentioned earlier, you know, like part of this work is also understanding our own triggers, our own experiences, how they show up in the work. When we're working with people, in systems that also don't care for us, as much as we can avoid being judgmental. So we want to be non-judgmental. Again, we're all taught to be judgmental. Every day we make judgments. That's part of the work that we do, is how those judgments are not there to create barriers or to harm or hurt people. And that means that I am going to be managing my own personal biases. We all have them. We're human beings, again, socialized in the system. So how do I acknowledge and recognize those biases? I have to look inside, right? And recognize them and know that they're there. And we want to be able to make sure that we're truly displaying empathy and that we really want to be empathetic towards people, right? And that means also that we have to be able to tolerate this ambiguity or this uncertainty that is part of this work. Harm reduction is messy. We live in we constantly move through these gray areas. And sometimes those gray areas, we want to know. Mark Anthony has a song, Mar Anthony, like we say in Puerto Rico, has a song, I Need to Know. Sometimes we need to know, and they have to tell you, many times we're not going to know. It's not going to be a full picture. And we need to kind of sit with that and acknowledge that it's not comfortable, that it can feel like weird sometimes. And we have, I mean, for me, having a sense of humor, right? Like having a sense of humor is a way of fighting against this system that constantly wants us to not feel joy and not feel pleasure and not feel connection to that and to others. And so ultimately, right, some tips for us that we can bring with us in our toolbox as we're doing this work from this lens of cultural safety is always centering and honoring people's personal autonomy and their right to self-determination. That is foremost in everything that we do, should be that. That should be like the, como se dice, the lighthouse, the light in the lighthouse, the thing that guides you when you're in a boat, whatever that is, or in a ship, you know, approaching our beacon. Gracias, Kate. A beacon, the North Star. Thank you. We want to approach our interventions from a place of curiosity and respect. And I think you were talking earlier about being from instead of like a judgment perspective, from a problem solving perspective. And it's asking ourselves, what may be behind this behavior? Why may this person be acting this way? Or what is that this behavior is signaling to me, right? From a place of curiosity and respect, so we can know. We want to go at that person's pace, right? And that means that sometimes we need to slow down a lot. Sometimes that means that we have to speed up a little bit, right? The pace needs to be established by that person, and each pace will be different based on the participant. We always believe in people's resiliency, and we focus on those protective factors that people bring and their strengths. We all have our strengths. How can I create room for that person to recognize their strengths, to see those strengths, to practice those strengths? It's like a muscle, right? So we want them to be lifting those weights to make them stronger and like create that muscle fiber. We want to be honest and transparent, right? These are the things that I can do. These are the things that I cannot do. These things happen. These would be the things that may come afterwards. Here are some of the things that I can offer in this case. Here are the connections that I can build for you. And always, 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 let's thank Kimberly Crenshaw for the gift that she's giving us of intersectionality, right? And it's really popular today. And also, it's been around for a long time. And how do we truly embody that practice of intersectionality with everything that we do in terms of how we approach our work and how we center people, because intersectionality is a way of challenging stigma as well.
And so let's kind of talk about how we can integrate and rethink, you know, some of these white supremacist canons, canone? I don't know how to say that.
Yeah.
Anyway, ideas, right? And so we should be rethinking about perfectionism, you know, where there's like little appreciation expressed for others' work. Criticism is more common of the person, of their work, or, you know, of the participant. We expect them to be perfect, and that is not, you know, we can't see mistakes as personal failings. So that's kind of like the antidote, you know, the developing cultures of appreciation, of learning, where it's expected that everyone is going to make mistakes and that we are going to learn from them. And, we can learn from somebody else's mistakes as much as we can learn from our own if we keep an open mind. And so let's also rethink only right way, which is the belief that there is only one way to do things right and that people will learn and adopt it. And so when they don't, then something is wrong with them. That's the assumption from the white supremacy culture. But, we can accept that there are many ways to get to the same goal. And we have to keep that in mind when we are developing care plans for our participants with them. There is not only one right way to practice harm reduction. There are many different ways that can look like. And so that's going to depend on what the person's goals are. And so, like Danaga has said before, we go at the participant's pace. And so that is fighting that sense of urgency, which is, like that there's little time, that really undermines democratic processes and thoughtful decision making when you're always thinking of, we need to go, 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 go. And if you have like 15 minutes for an intervention, like how much can you really do in 15 minutes? So you need to kind of set realistic goals and work plans with participants, knowing what time you have. And so another idea that we kind of should be rethinking is defensiveness, where the organization and the energy is focused on preventing abuse and protecting people in power. And so criticism of those in power is viewed as inappropriate. Challenging ideas are kind of hard to bring up. So what can we do, to like as an antidote to this? We need to understand how defensiveness is linked to fear, either of losing power, losing faith, or losing comfort, or losing privilege. And we should be able to name it as a problem when it is one. And so that takes us to individualism. So, our society has been built on us working as silos. And so little experience or comfort is found in working as part of a team. And so people feel responsible for solving their problems alone. And so that's something that our participants really, really take to heart. Like, this is a moral failing, going back to stigma. This is a moral failing of mine, and I am the one with the problem. So I need to be the one to solve it. Even when they come into your office or when you're doing outreach and they're telling you that they want help, our society is still thinking in an individualistic way. And so we should, in organizations, include teamwork as a value. And we should give credit to people that participate in creating or providing services. And not just the leaders should be the ones taking credit, because the leaders are nothing without the people that actually do the work. And so that also takes us to power hoarding, talking about the leaders. Like, there in this society, there's little value around sharing power. And us as providers, we hold that power. And so we need to let go of that control and let go of that authoritarianism and just kind of assume with respect and curiosity that we do know stuff, but that the other person also knows stuff, a lot of. And so we in our organizations as well as in our individual interventions, a way of avoiding power hoarding is power sharing. Discussing how leadership is going to evolve in organizations, and also how your relationship individually with the participants is going to look like. And so that also takes us to another one of these ideas that are really pervasive, which is either or thinking, the binary. Things are either good or bad, they're right or wrong. It's us against them. And so when you take a stance as, an us against them, you tend to dehumanize the others. And so the people that we work with, and even us as service providers, we have been othered. And so we need to fight against that by providing more than two alternatives. Like, no, we can work together in tandem to a common goal. It doesn't have to be either you win or I win. And so the last of the these ideas that we should be rethinking is objectivity. I mean, how objective can we be? I had a teacher in high school that said the only things that can be objective are objects. And so um and so we need to remove that belief that emotions should not play a role in decision making or group processes. And I feel like emotions are information that let us know ways in which we can step forward. It doesn't mean that we need to make decisions when having a strong emotion. It means that that can inform, your thinking about a certain problem. And so that could be taken to us as providers, like, oh, this triggered me. Okay, so I can't be objective because this triggered me, but I can be unbiased, which is different than being objective. So yeah, let's take it to Tanagra for other lenses and that we could use frameworks.
Thank you, Gabby. And so when we're thinking of dismantling stigma, these are all tools and frameworks that we have that we can derive from to be able to reshape the way that we see and work with people. And another lens that we can use, or a new lens that we can bring into our work, and I think Dante mentioned some of that already in the chat, is language justice, right? So when we think of language justice is an approach within social justice movements that is, again, seeking to share power with people and practice inclusion, because what we're saying is we're breaking this idea or this norm that the only dominant language that can happen in the room is English, right? That's the only official accepted language, right? So we're creating spaces where people can come as they are and communicate authentically and genuinely with each other, right? We're creating spaces where true participation can happen, where language is not a barrier for people to be able to find connection to each other, to express each other, to be. And this is not only English or Spanish, it's other kinds of language, right? I know I've been in meetings with people when they're using all these different acronyms, and I'm like, I don't know what you're talking about. It sounds like a new, like, I have no idea, because I was new to the meeting and I was new to the space, and I didn't have like a guide to the acronyms, right? So I couldn't fully participate. And I see that in social work, I see it in harm reduction, right? We have all these acronyms, and for someone that is new to our movement and to our work, it may feel really hostile, right? And so language justice is saying, hey, I'm going to buddy up with you. I'm going to set up for success. I'm going to figure out a way so you can also, to feel that you can create a space in the room where people can ask and say, hey, without feeling dumb, right? Because sometimes they make feel us dumb. Hey, what does that mean? Can you explain what that acronym means, or those words, right? Or those letters? Not assume that everybody's going to know. So we're setting up people to succeed by that lens of language justice. And it's calling us also to disrupt colonization, white supremacy culture, all of those tenets that Gabby shared. The root of that is colonization and Western dominance. We're challenging that. There's many different ways that people have organized themselves and continue to do so across the global South, that are less individualistic and much more rooted in the collective and in the relationships that we can have with each other. So let's look at those, right? We can break down the ways in which injustice silences us, erases us, and dehumanizes us. If you don't hear my voice, if you don't hear me speak, si no me escuchas hablar en el idioma en el que yo me siento que soy humana, right? In the language that I feel that I'm human, I am not human, right? And many times we cannot participate in those spaces because we don't feel welcome, because we don't feel seen, because we don't feel we have room. We want to create spaces where everyone can be welcome to communicate in the languages and accents, that they feel most comfortable and whole. And finally, we want to make sure that we're letting people know that the standard Anglo-Saxon American English is not the only English, the only language that exists. There are many others, right? And there's beauty in that as well. And another lens that we can bring to this is another lens is the lens of healing justice, right? We have trauma-informed care, and I want us also to think about healing justice as a framework, right? And it can help us to, again, be holistic, which is a theme here, when we're responding and intervening within when there are events that happen that have to do with generational trauma or violence, right? By bringing in and calling in these collective practices that can help us transform the consequences of experiencing oppression on our bodies, on our hearts, on our minds, right? Again, we're full human beings. We feel it in our body sometimes before we know that it's something that is rooted in our heart. And so that piece is really, really important. And we can bring in this healing justice principles to our work by recognizing that trauma is collective, that is not only individual, that I can experience individual trauma, but also we need to look at what we were saying earlier, right? That there's collective histories of trauma that we need to understand and comprehend, because if we don't do that, we're gaslighting people, right? There's not one single model of care, so no one size fits all again. We should be making sure that our practices are as diverse, culturally safe, and tailored to the needs of those communities and the individuals that we're serving and the people that we're working with. Again, if this sounds familiar to harm reduction principles, and it's because I see them very much connected. We want to uplift, center, and protect and respect community autonomy and agency. People have the right, communities, just as individuals, communities have the right to determine what their own healing strategies and practices look like. And they should be led by the community, and we should center that self-determination. They should also be rooted in place, right? It should be rooted in the specific context and history of that community, right? Drawing from those traditions and knowledge. And I think sometimes we may be in a space where we are witnessing a practice. For example, I've been to the White Earth Harm Reduction Summit that happens in White Earth, the Native Harm Reduction Summit, and they have a practice where they allow you to smudge and to use tobacco as part of the cleaning of the energy. And that is beautiful, right? And also that's not a practice of my people, right? And so as much as I would like to use that, I feel that if I didn't ask for permission, I would be violating and misusing that practice. So I need to find my own practices for my own healing, right? Like rooted in the place where I'm at in my community with my people, right? We need to be bringing an anti-capitalist, Black feminist, brown feminist, indigenous feminist, abolitionist lens to everything that we do in this work if we want to heal, right? It is rooted in this perspectives and this ethos, right? Because these systems have been set up to perpetuate trauma and oppression, right? And to only uplift, center, and privilege the experiences of a very limited group of people. And we need to constantly ask ourselves, are we centering those voices that are most marginalized? How do we center those voices that are so important for us to hear? Carmen Maria Machado has a book, In the Dream House, and she opens that book, which I'm obsessed by, with this notion of the archive, right? And who gets to create the archive that holds the data, the information, and what data goes in there, right? And so what she's saying to us is like, we can create alternate archives that are also uplifting and centering the voices of those that are most marginalized, right? We can create a counter archive, that holds those experiences and those voices so they're not lost. The book is In the Dream House, and it is an amazing book. I highly recommend it. And that notion of archive has had me obsessed for a long time. And so thinking about centering these voices is us helping with each other create this alternate archive that is legitimizing and giving voice to those voices that have been kept voiceless.
And so there's also bringing another framework to help us, kind of support our person-centered, trauma-informed care, etc. Like everything we've been kind of building upon. I'm gonna read the quote because I feel like it's really powerful, by Patty Byrne from Sense and Valid. This is disability justice, an honoring of the long-standing legacies of resilience and resistance, which are the inheritance of all of us whose bodies or minds will not conform. Disability justice is a vision and a practice of a yet to be, a map that we create with our ancestors and our great grandchildren onward, in the width and depth of our multiplicities and histories, a movement towards a world in which every body and mind is known as beautiful. So, this is basically telling us that we should embrace all of ourselves in whichever ways that we show up to the places that we show up to. And disability, it has to do with mind and body. And so the people that we support in our practices can see themselves as disabled, but they're also resilient, and we should focus on that. And so some disability justice principles are very, very interconnected to the healing justice principles. Intersectionality, we do not live single issue lives, which Audre Lorde said. So like we've been saying, with intersectionality, we are made up of a lot of identities. And so we get to decide what we own and how we define ourselves. And so that is justice for ourselves. So leadership of the most impacted, I feel like we've talked about this a lot. Recognizing wholeness. So we are people as a whole. And so we are worse outside of commodity relations and capitalist notions of productivity, which is what disability justice is about. Like we sometimes discard people because they can't be productive for capitalism. And so that is something that we really, really, really need to challenge. So another principle is sustainability. We need to pace ourselves individually and collectively to be sustained long term. And so we need to think about the world and ourselves in longer terms. You know, how can we survive 200 years from now? Because at the pace that we're going with climate change, I don't think that's possible. So that is something that we need to keep in mind. And the same goes for individual interventions, like with your participants. What pace is sustainable for them, so that they can achieve their goals. And so we need to recognize as well that we are interdependent. We meet each other's needs as we build towards liberation, knowing that state solutions inevitably extend into further control over lives. So if harm reduction has shown us anything, is that we only we will save each other. And like from the ground up is how movements are built, and that is how these principles came to be, from the people that are most impacted in a sustainable way, recognizing our how interdependent we are. And so the last principle is collective liberation. So no body or mind can be left behind. And so that includes us as providers, our participants or clients, the janitor, everybody. It includes everybody. And so, yeah, I just want to leave you with a question. So how can these frameworks and approaches be helpful when working with people experiencing co-occurring disorders? You know, you don't have to think about it as co-occurring disorders. You can think about it as, people who use drugs and also have mental health issues. But how do you think that these frameworks and approaches can be helpful? You can type it in the chat if you want. If you have questions, the Q&A is open.
Yeah. I think I'm gonna stop sharing. I'm gonna copy this and put it in the chat, and then I'm gonna also share the slides with folks. 1 second, so that I can stop, exit the slideshow, copy the question. So I just copied the question, and I'm gonna share the slides.
And if folks want to share with their voices, feel free to do the raise hand function, and I can allow you to come.
Thank you, Harmony. Oh, I'm sorry to hear that, Hannah. Absolutely.
Oh, yeah.
Yes, Sarah. allowing them to be experts in their own experience or needs. Absolutely.
And remembering this, nadie es desechable. How do you say that in
Yeah.
English?
Nobody's disposable.
Yeah, exactly.
Yes, you will have access to the slides. I just linked them, Kathy. I'm gonna link them again. I just shared them in the chat. But let me share them again. And then the recording will be sent out at a later date with an email. I just share them there. It helps create good rapport and trust, absolutely. Particularly when folks are coming already from a place of maybe defensiveness, because you know they don't have to trust us, you know, like it's not us as a people, us as a system, and we represent that system. So again, as Gabi was saying in the beginning, you know, the more that we can sort of root ourselves and this is not personal to us or about us, right? The more that we can then start building those spaces of trust and of relationship.
Thank you,
Thank
Connie
you.
and Jenny. And Dante, yeah,
Yes.
this is methods like peer supports to our work. Definitely. Interestingly enough, in Puerto Rico, peers can get certified, but all the peers that I know that have the certification are abstinent. So that is something that we also can be working on, at least in our context. You know, kind of seeing the peer as a person that can still be in use and still provide support. I mean, I use drugs and I support people, and I'm not a official peer.
Yeah. There's a question from Gina. I wonder how about these approaches help with setting boundaries between everyone so trust can be built. There seems to be much harm within the power differentials. Absolutely. And I think that recognizing that power is there, that participants have power, then we have power, is who gets to apply the power and how we apply it. What is the framework, like the framing that we have for that power, right? Are we using our power to open doors when they need to be open, or are we using our power to continue to close doors, right? And when we think about all of these approaches, such as language justice, cultural safety, trauma-informed care, center engagement, disability justice, it is about collective power, right? And it's also about thinking how are we in relationship with others, right? So how do we want to be in relationship with others, and how can we bring the ethos of intersectionality, of collective power, of personal autonomy and collective autonomy, of mutuality, right? Which is also part of harm reduction, solidarity, into that space. So that's a great question, Gina. And then
also I was thinking that, you know, when we find ourselves in situations where we can enforce our power, we need to question what, like you were saying, what do I want to use this for? Like, I have a friend that whenever she steps into a space and is given a microphone, she will pass it around to the people that never get that mic, you know, because she's a white passing person and is recognizing her privilege. And so is doing, okay, so I've said what I need to say, but there's other people that need to say a lot more. And that happens, you know, in individual relationships as well as in collective spaces.
Yeah, thank you, Shavidi. This helps remove barriers and support people's goals. I don't know if folks have questions. If, as Harmony said, if you want to share and want to share verbally, you can definitely use the microphone. Would be happy to hear from you. Let me see. David just shared something.
Yes, David. So people, yes, that have lived experience, we have a lot of wisdom that you know is often taken for granted. And so yes, definitely centering those voices and that wisdom is central to harm reduction and to fighting stigma as well.
Yeah. I think, Gabi, something that you mentioned that really struck with me is this idea of how perfectionism perpetuates stigma, because it's asking us to be unrealistic about the human beings that we have in front of us. None of us, as far as I know, are perfect. And if we're trying to be perfect, all we're going to do is burn ourselves out, because perfection is unattainable. It doesn't exist. It's whoever's bar it is, and it's not our bar. And so whenever we sort of look at other people, it's like, if we can extend that kindness of saying, hey, people are going to screw up. We are going to screw up. People, we're gonna potentially cause harm. And people are going to cause us harm. Is how we engage in that repair, right? We're talking earlier. How do we create a space where we can be in principle struggle with each other, when we assume that even if harm has been caused, we're still coming from a place of good intention, right? All of those pieces are really important, right? When we're thinking about, you know, doing this work, and particularly when we're working with people who use drugs, like, it's not to romanticize them, right? Because that harms people who use drugs too. People who use drugs are people. And they're not perfect, and we cannot expect them to be perfect, just as we don't want people to expect us to be perfect too.
Yeah, I like what Angela said in the chat. Myth busting, lean into difficult conversations. I feel like that is something that we are not taught because of the perfectionism that is expected from us. We are not expected to make mistakes, and we are, if when we make mistakes, we don't know how to have these conversations. And so that is something that we have to actively work on, and that also helps with boundary setting. You know, like, these are the mistakes that I know I have made, and to avoid